And I'd like to introduce, as he comes up, Dr. Leo Elwell. And Dr. Elwell is a psychiatrist who specializes in addiction and post-traumatic stress disorder. Based in Edmonton, Dr. Elwell spent much of his career with the Canadian Armed Forces. Since 2013, Dr. Elwell has been working in Whitehorse at Mental Health Services, Alcohol and Drug Services, and Whitehorse General Hospital. He's also board certified in the U.S. in psychiatry and addiction medicine. So please welcome Dr. Elwell.
Wow, hi everybody, I'm Leo. Hazel, I had a question. How do we really start changing some of the money more into primary prevention? For alcohol, okay, there's for sure documented really good evidence that screening, brief intervention, referral for treatment works. The research hasn't been good enough on opioids yet for primary prevention, but certainly for secondary from the addiction medicine literature. I'd like to thank the TAN Council and the Kwame Dunn Council for having us here. Thank you. And I'd also like to mention that the fire was something that I participated in this morning. So this talk is dedicated to my brother, who's missing somewhere in Ontario, and he definitely has drug addiction problems. And are we moving along? There we go. So just to get some ideas as to what we're dealing with, okay, it's an illness that lasts a long time. Everybody thinks, oh, it's just rehab and then everything's all fixed and it's all great. And it's like, no. We're in this for the long haul. And so, again, primary prevention, if we can prevent this from happening, then we can probably save ourselves a lot of money, let alone we'll just ignore all the human suffering. We'll just talk about money, right? And so if we've got these circuits not working properly, there's a lot of things that happen as a result of those circuits not firing properly. And if you've grown up in a family where there's addiction kind of issues, you certainly get to experience that firsthand. And you see a lot of really difficult behavior, and that's an understatement. So we've got diminished behavioral control, we've got craving, we've got diminished ability to fulfill roles at work, at play, in community. And like these other chronic diseases like diabetes, like high blood pressure, all of them, we have waxing and waning of this condition. Sometimes it gets better, and sometimes it gets worse. And sometimes when you need lots of treatment, you have to go to full-on tertiary care in, for example, the Sarah Steele building. And then at other times, you don't need quite as much care, and it can be handled in the community, it can be handled in self-help groups, it can be handled in 12-step, etc. And then one of the things I want you guys, as we're going through this process, how do we measure the impact of a person using a substance? And we can put in there opioids, whatever kind they are. We can put in there alcohol, an oldie but a goodie. We can put in there tobacco. We can put in there, you name the substance of abuse. You can think of it in the same way. So how do we measure what substance abuse looks like? What substances are being used? And typically by the time people come to see me, it's not just one. I actually get excited when I only have to deal with one, because it's like, yay, it's simple. And then how do we measure the outcomes? What does recovery look like? What does health look like for a person with this chronic, ongoing, long-term condition? Severity of it, different factors including age, gender, ethnicity, and man, I wish there was a screen right here. And then other co-occurring disorders. And I think I'm really lucky, like I did 10 years of doing nothing but trauma and substance use work in the military before coming up here, so I've done a bit of it. And although the trauma is different from military-induced trauma amongst many of the people that I have the fortune to meet with in my work, there's a lot of things that we can apply from that. And one of the big things that we learned in the military was the notion of community. So community, belonging to the regiment, belonging to the battalion, belonging to the forces, was a huge part of how the guys and gals would do in recovery. If we can have that same thing happening here, it's not as well described in the addiction literature yet, but it's definitely there in the military addiction literature and the military trauma literature, is the notion of community and community support. And so this is at the level of secondary prevention typically, but it is really important. And I love it when we have a person that's still connected to their job, still connected to their family, still connected to their cultural group. It makes my job a heck of a lot easier, and that's a good thing, because it's not an easy job some days. So then we have to look at what are the outcome measurements, because remember, we have to keep political people higher up all happy and saying, yes, we're spending our budgets properly and all that sort of thing, right? So one of the big things that helps people stay honest in this area is urine drug screens. And if anything comes out of this at the policy level, man, would I sure like to have some increased urine drug screening done in this territory, because it's a very useful tool for me in my work and for other primary care people as well to monitor how a person is doing in their recovery. And we can define it in tons of different ways. We can look at school attendance, work attendance, how job performance is happening. And at the end of the day, what we're trying to do is cut down this last part. Now, we don't recognize this utilization of services all across these different departments because none of the departments talk to one another, right? We're all in these silos. So if one other thing that could happen on my wish list here of policy is that getting the different departments to talk to one another to say, okay, this is how much Mr. or Mrs. Smith is burning up in terms of dollars over in our department, and this is how much they're using over in this department, and then adding up all those costs. And every homeless person in Calgary, there was a beautiful year-long study done where they looked at the total costs, and it was, when you added up the healthcare costs, the social worker costs, the sexually transmitted disease costs, when you looked up housing, shelter costs, police, fire department, ambulance visits, and all that, it was crazy. It's cheaper to buy a house and put the person in it, okay? Which, wow, you know, but because we don't talk to one another, okay, we don't know that. We don't know the true cost. And then everybody's trying to protect their own budget, right? And we don't get a sense of how much a person with an opioid addiction, an alcohol addiction, whatever addiction, how much they're costing the system as a whole, let alone the human suffering. Not just one episode, so I repeat myself a lot because some of my people don't have really good short-term memory. And so I'm in the habit of doing that. And arthritis, diabetes, high blood pressure, chronic, relapse, remitting kind of disorder. So currently we have a one methadone clinic, and a lot of people really trying to do a good job there, but, and I hate to say this, but it's so 1970s, you know, and I think we're past that now in terms of addiction medicine. I love what they try to do, but one of the small problems that's kind of unique to a city the size of Whitehorse is that you get all the opiate users in one room on one day. What could go wrong, right? Right? Okay, so, it's like, oh, there's Billy over there, and we got high the other week. Oh, maybe he's got some new stuff, and boom. Man, talk about a recipe for disaster. I think that we have to up our game in monitoring at the pharmacy. We have to up our game, what I do, what other prescribers do in terms of, some of this stuff getting diverted. Urine drug screening, current state of affairs, not just at methadone, but in other points of care. Aside from the emergency room, we don't have point of care testing for drug screening, and yet, according to my professional body, the American Society of Addiction Medicine, this is really essential, right? The costs, different costs of treatment, and then in addition to that, at this one particular place, we don't have on-site access to counseling or other social supports, right? So it's like, okay, we're doing a good thing, but we can definitely be doing it better. And it doesn't really quite meet what the American Society of Addiction Medicine defines as a gold standard kind of treatment program. So then going over to the lovely new building at ADS, which I must say, the air quality in there for my breathing is much better than at my other job at Mental Health Services. I just thought I'd mention that. Anyway, just saying. We have a lot of different programs, and what I like about this is that we have inpatient, outpatient programs, okay? So there's that, when the person needs lots of treatment, we can give them lots of treatment, but when they don't need lots of treatment, we can back right off, okay? And then, depending where their needs are, we can either be in there guns blazing, or we can back right off and just see them once every 6 months or whatever, and then keep the intervention really light for them and save money, right? One of the things that I have noticed is that when we're moving people around in the system, so going from the emergency department upstairs to the SMU or around to the hospital, dealing with whatever complications of the addictions they have, then back out to the ADS, then out to the community, then to the GP, that's where they fall through the cracks. So I'd really love a way that we can figure out transitions better. I don't have an answer on that, but I really like it to happen, because that, we lose people to follow up easily, I'm gonna say 2 a week, okay, on transitions. And then, if we get lucky, they come back and they're still alive, and then we can keep on going, but sometimes it doesn't work out that way. Did I mention the urine drug screening? Yeah, I did. Okay, repeat yourself again, Leo. We need to build more capacity. We got 30,000 people up here, and there's certainly a lot of demand for certain individuals in the system, Dr. Lazio at Taiga and that. But what happens when, Sharon retires? You're not retiring, right? Okay, no, okay. What happens when I retire? What happens when other people leave the system, right? Like, how do we ensure that there's somebody keeping this going? And I think that we need to look at innate, built-in capacity to do that. So we're bringing up residents from the South in psychiatry to try and train them a bit and get them exposed to Northern life and get them, sort of enjoying it, right? So that maybe when they graduate, we can grab them, okay? And at least get, 1 or 2, not just in mental health, but in addictions, et cetera. The other thing, and I've been preaching this gospel for a number of years now, is the amount of screening that we're doing. We have to do more of it. If we pick up an illness early, we can do something that's effective and cheap and that preserves the person as a functioning taxpayer, let alone a human being. And if we wait until it's getting to my stage, holy smokes, it's a mess, and it costs lots of money, and it costs lots of time, and there's been a lot of suffering that goes along the way. If methadone's done well, it works. You can't argue that point on with me because there's a stack of literature from the floor to here. It works, definitely works. And, hello. I am clicking this. Uh-oh. Can you advance the slide? All the lights are on now. Not a good sign. So office-based treatment is something that is recently coming along, and it's basically saying we're not going to treat just in one place. We're not going to treat just in a methadone clinic. We're going to treat in multiple locations in the community because guess what? It improves access to care. And if it's the primary care person that's taking care of this patient, there's already a bond there, okay? I come in on it, and probably a good 15 minutes of the first meeting together is about establishing a bond, which the primary care physician, because they've known him for however many years, boom, they've got that already. They're chronic conditions, so again, if they're in primary care, we can take care of the skin infections, we can take care of the foot ulcers, we can take care of, hepatitis, we can take care of all the other complicating stuff, and then I don't have to do it. Oh, did I say that out loud? Sorry. No, it's better if it's done in primary care than me doing it, okay? Or people like me. With support, though, because one of the things that the feedback I've gotten from the GPs in the community is that, oh my gosh, I get this complicated, addicted person, what the heck do I do? And it's like, okay, I've been doing it for a number of years, so I sort of know what to do, but I'm still learning. That's why it's called the practice of medicine. You keep practicing. But I think we need to do a better job of trying to support the GP, the nurse practitioner, the people out there in the stations in the community to say, hey, this is what you need to do with this person. And I love my pharmacists in town. Thank you guys, thank you. You saved me, and I appreciate that. And collaborating with, who are the people that they're worried about who are receiving their opioid substitution therapy, what are they seeing, because I can't be everywhere at once. Sorry about that. Yes, and then in the communities, how do we do stuff like that? I could see where if we're doing something a little bit more complicated, like starting Suboxone or starting methadone, that it happens in Whitehorse, but I'd prefer to treat the person in their community, remember, because community is important, right? Is there a way of, helping the people out in the community, the nursing station people, to say, hey, do this, do that, Is there a way of them phoning us, I don't want phone calls 24 hours a day. Thank you very much. I value my sleep. But is there a way that you guys can feel supported? Oh, 2 minutes? Okay. I better shut up. Now it's working again. Office-based care handles a bunch of different things. It's not just, doctor stuff. You're addressing a lot of what's happening in the family because, again, remember, the family, of course, is not impacted by the opioid use disorder, right? Right? Okay, yeah, okay. Did I mention urine drug screens? Oh, good, okay. And then there's that waxing, waning intensity of treatment. And I hate wait lists. They suck, and we need to get rid of them yesterday. And remember the transitions, like when a person moves from one aspect of treatment to another, that's when we lose them. We got to keep that working better, and we got to talk to one another. We got to be a community. And I don't have a lot of answers on underserved areas out in the communities, but I think Suboxone is probably the way to go as part of this multimodal treatment. And the other thing is these are the references, so they should be in your package, and those links worked as of last month. So, they're really good to read. I like the BC guidelines, and that's probably the way that we're going to be going. I love ASAM. I'm a huge member of them, and now I'm shutting up. Questions?
All right, is there any questions right now for Dr. Elwell? Nope. Over here, do we have a mic for Patricia?
Thank you. Good morning. Thank you, Dr. Elwell, for your presentation. I'm Patricia Bacon, Executive Director for Blood Test Forward Action Center. My question is, can you talk a little bit more about your obsession with urinary drug screens? From my lens, so here's my question. This is why I really want to be informed. From my lens, a urinary drug screen with the people that we work with can be seen as a barrier to staying engaged in treatment and even accessing treatment, because a urinary drug screen can be seen as punitive. It can be seen as a way that they might have failed if the screen doesn't come back clean. And so we see people that are worried and they have a lot of anxiety if they're in a methadone program or some other treatment program, that if they can't get a good screen, that they're going to get kicked out of a program. And so it's seen as, from us, we can see it as a lot of times barrier and stuff. But you did hint at that it can be so helpful. And I was wondering if you could explain that side and how you balance those two pieces, because I'm sure in your experience too that you've seen that some people look at a urinary drug screen as punitive or problematic. So could you speak to that a little bit more?
I
Thanks.
completely agree with what you've said. Urine drug screens done properly are not punitive, are not, the stick, are not, you've failed, you suck, that sort of thing. Urine drug screens done properly are a tool that allows the clinician to engage better with the patient. But all of your comments about how urine drug screens can be used are the way they're not supposed to be used, okay? So certain individuals use them in a certain manner, but part of, if we go with this route, is that the UDSs will be used very, very differently than what's been going on. Because I don't like it at all, the way that certain people use it. It's wrong. R-O-N-G, wrong. So, does that help? Okay. And I'm also available at lunch, right? So.
Great, thank you. Any other questions for Dr. Elwell? Oh, yeah, there's a gentleman in the back there. If someone has a mic for him.
Thank you for coming. My name is David. I've been up here many years. I hear of alcohol, pills, liquor. I never hear the word loneliness. It hurts. Do you think it all started with that?
I think that there's a lot of stuff that happens in people's lives growing up that hurts them, and I agree with loneliness. I agree. Yeah.
Yes, I did. A young man went to prison, and there were gangs in prison, and they said, one gang member said, "We want you to belong to our gang." They figured he was the first time that he heard, "We want you." He never heard it at home.
That's right. That's part of the family thing, right? Because you want to belong to something.
Many here today, they feel loneliness, and it hurts. I've been there, and it troubles you or hurts you. Maybe you lean on something else. They weren't bad people, young people. I have 4 children. They went through teenagers. I know what it was like. They all went through successfully. My father kept me so busy, I didn't have time for anything else. You think that would be it? Be busy?
I think
Take time for someone?
I think being part of something is super important.
Okay, we take time for that. We don't need to go to alcohols and millions of dollars enforcement or things like that to subdue, to bring the crime down. It's for people to be with people, to take time for your own family.
Yep.
Okay? I thank
agree.
you very much.
I agree.